Welcome everybody to another Saturday, another morning for some places, and afternoon for others, and night for other places. Because here is an international meeting, and sponsored by the American Academy of Thermology. And today, the AT proudly invite you to our medical minutes with Dr. Sergio Andres Machado Passio. He's a doctor from Uruguay. And as I'm saying, Passio is rising star in the world of infrared imaging, a recent member of the American Academy of Thermology, and already showing incredible results applying infrared in complex, high-stakes medical environments, including intensive care, burn surgery, and pediatric wound care, and other complex cases in hospital and clinics. So if you care about the future of infrared imaging in real clinical settings, if you want to see how new talent is pushing boundaries in medical thermology, if you're serious about staying ahead of this field, today is the day to see the presentation of Sergio Andres Macho Passio. And before to start, I like to remember everybody that here is open for everyone to take part. So enjoy yourself, share the links, and we have the YouTube channel, we have the podcasts from the American Academy of Thermology. You'll find this easily. And we are open here to sponsors our channel too, sure, and our meetings. And the main aim here is to share acknowledgement from everybody, everywhere that has interest on infrared image. No mind how experienced are you, what you have to present. We are open here to listen everybody. Okay, welcome. Thank you, Sergio, and for taking part today. And we are very excited to listen about your presentation about wounds at point of care or point of wounds. Thank you so much, Sergio. Welcome again.
Thanks so much, Professor Marcos, everywhere. Thanks so much for everybody who are here this Saturday for 50 minutes medical thermology. I will share my presentation, Marcos, now. You see the full screen?
Yes, it's okay. Thank you.
Okay, 1 minutes. Okay. Okay, hello for everybody. Marcos sharing my curriculum, and the next point is share information. I'm medical research and thermography specialist for Uruguayan Association of Medical Thermology and professor for assistant academic toxicology and occupational health units for University from Uruguay. Now, we research for too many teens inside and pediatric and adult hospital investigation units, enteral and parenteral nutrition units for palliative pediatric patients, servicing for rheumatology, burn and reconstructive surgery units, and toxicology, poison, and venomations. Everybody knows the points, the infrared imaging about the wounds, because the most important points that's no adverse effects, no radiation, no ionizing radiation, applying in critical patients inside operating rooms, outpatient clinics, used a static thermography, dynamic thermography, and reconstruction 3D thermography. Remember, it's a functional, not anatomical study. And the imaging needs acquired by healthcare personnel and teaching and learning thermography in bedside. and needs to be operated by software. Uses different sensors and in bedside acquiring imaging. And acquiring images in the point of care is the real point. It's but different from laboratory imaging thermography, because in control rooms, the humidity, temperature, airflow, thermalization is every control. What's the problem? The problem is outside from control areas. American Academy of Thermology applying guidelines for point-of-care medical thermography that approved it. Yes, for Professor Robert Schwartz and committee inside Marcos Brioxin and others, and applying for first guidelines for thermography applying in point of care in bedside. But the real point is, how do you work in environments, extreme environments, palliative care units, operating rooms, intensive care units, birth units, and the best of extreme thermography, neonatal intensive care units. In Uruguay, Outterm work making guidelines for critical care areas, CCA Outterm protocol. This is applying in these inside areas from facilities, overall approaching the thermography extreme conditions. That's the point. Palliative one team from operation inside pediatrics hospital includes CCA protocol, making continuing education from CCA protocols, nurses, residents, graduate students. And for us, the most important point is knowing technique by team members. Look at that. We remove this one. Okay. In point of care, it's most important, not only formal personnel making medical thermologists applying the thermography, but the rest of the team know it and using and acquiring imagings in bedside, applying the CCA protocols. Look at that, my nurses team acquiring imaging from the patient with follow-up, and acquiring critical imaging from decisions from the rest of the pediatric team about these patients. Not important the case, the important now is the former personnel and applying and acquiring imaging in bedside. Look at that, the imaging acquired by nurses team, and follow up and making decisions between specialties in real time on bedside. Others are making a continuous learning and training with specialists and bedside. Thermal ones in the first team, specialty, follow-up and researcher, and wounds in adults. Professor Lucia Garcia Parodi and me work together in real-time thermography for acquiring quality imaging in bedside, similar to this. Palliative one team follow up the catheters infections in palliative unities. For this one, it's very important and understood the limitations of thermography in point of care. First, temperature inside the room. Second, inside researchers and tutors inside of the room. This room is too much little, 3 for 3 meters, and making many people affected the possibility of the thermal interchange. Look at that, that's acquired imaging by nurse team and palliative wounds. Other complex scenario is operating rooms. Why? The preparation of a birth patient, for example, for a sclerectomy, the thermalization is a limitation for critical patients in the operating room. Why? Because they lose heat after 10 minutes of anesthesiologist report changes by hemodynamics instability and due to absence of physiological response of heat loss by conduction and convection. This is the big problem. Why resolve that? Look at that. This is the example for inside room work Sergio and plastic team thermology, making many people inside the room, but the room is too much bigger. Yes, look at that here. The airflow is in front from the camera. This is possible to limitation because airflow inside the room, making affected the final analyze imaging. And next point, we need use dynamic video thermography because it's too much important from the team in same time analyzing and see the modified tissue, remove tissue, necrotic tissue from the burns. Look at that. This is projected by TV inside the room. In same time, the surgeon remove sclerectomy, electric scalp, at the same time. It's too much important. This is the first description and from using the thermology, real time, same time, we should specialize team. For X degrees for areas needs to be removed inside the room. This is another. Looks
Dale,
like
soltalo porque estoy grabando.
this is a verification
Esto lo que les muestra es el
by
flujo
vascular
vascular inmediato en la piel, ¿no?
clamping plastic surgery by video thermal. She needs
Y ahí vamos a ver
S.
cómo recupera.
Those
Es que la parte distal sigue. No quedó, la parte superior sí.
Sí,
Mira cómo va
esto-
recuperando.
outline
Mira cómo va
vascular
recuperando, ¿eh?
area
Va pasando de azul al...
Todavía flujo.
Sí, hay
bueno,
flujo
por
distal.
eso
because
lo que yo
needs
quiero
to
es
remove
hacer
the
Lo que
pedicle.
vamos a hacer ahora es como lo mismo que hice ahora. Vamos a
Porque lo que va a quedar es esto igual.
La parte distal, sí, pero mira cómo va retornando a la parte superior.
Quiere que le ponga
This
de vuelta
technique
para
Vamos
is
una vez
only
más si
one
querés.
for
no queda
C
bien precisito.
behind
Dale.
optics. No technique for over the echo sound or flicks. This is the flap.
Miren, ahí la parte bien distal de la
And
nariz.
needs to be applying
Vamos a subir.
dropped flow observed.
Ya, el tuyo es el negro, vos estás arriba negro. Vamos a ver para atrás. Muy
The
bien.
next step is to remove the pedicle. It looks like here using scalp, electrical scalp. Look at that, the ROI is no clear for CT. This is one limitation because modify total area. But if you don't use it, the classical scalp, remove tissue, no available.
Aparte sería redondo para demostrar que no lo cortamos.
This is a bite
Pitbull.
from a pit bull
Ese
on
marrón.
the face
Sí, pero viste que
of
los
this
perros le
child
pegan, les hacen
Tenemos
de
uno con,
todo.
una con titulares.
and needs to be reconstructive surgery. It is a fantastic user for thermography inside the rooms.
Y aparte no te olvides que la piel me traen a mí.
Listo, te pido una...
Menos es más, aprende que en los niños no hay que resecar de mamá, vale que sobre. ¿Por qué? Porque siempre la piel retrae, y más en los niños, siempre te quedas corto.
And the follow-up, the child reconstructive to prepare your nose and see life again. What's the point from burn patients? From the burn patients, the most important is in pediatrics is the correct thermal window, and not variables from modifying the last imaging. Can you hear me? Okay.
Yes.
Yes.
Yes. Okay. Look at that. This is a child from hot water about your thorax, and from the first registry and the imaging. Looks that. This is one problem. Here, the hands of your mother take it to the picture and modify temperature acquiring imaging. For the pediatrics, it's a limitation because the child is not simple to acquire it and thermal window and perfect thermal window. It's most important, make sure the areas of interest are not supported by hands. If it's not possible, adjust the sensor to the best position and take several imagings, not only one. If possible, place the patient in thermal window position. See the next imaging. This is the first thermal position. No hands on your parents, and it's must clear for analyze the imaging. From intensive care one team, we apply guidelines for critical care areas. First, in intensive care, there is small areas limiting entry for the personnel. To be needs acute artificial light and needs to close the windows to avoid natural light, because this affected imaging. It needs to be pre-exposed areas to be studied. Use the most appropriate field of view based sensor and use what do you want to be observed. Here we can use it sensor field big field of view and a little field of view. Too much and acquiring imaging a different distances from the patients. Looks that without the limitations we're talking about in here, this is a classical patient over the echo sound, tomography, and clinical, not resolve that. These are pediatrics, post-operative wound without fever from source. The ultrasound did not detect collections. In 48 hours, see the arrows. See the wound examined, not any clinical things. Perhaps the question here or here affected erythema, edema, flow, never. But thermography analyze and see the hyperradiation area. It's no problem. It's inflammation, 2 weeks post intervention, post-surgical, but the area see that, and here, clowns observed. Analyzing reconstruction 3D and see 48 hours follow-up. This is the case from the fever. And thermography identify 48 hours after. Needs to be removed, and clinical treatment by antibiotics and follow-up is outcome. But the extreme area, and for us, extreme hard thermography, is neonatal intensive care units. Why? The scenario is no compatibility from the sensors. The incubator works intermediate temperature, about 36 degrees. Restrictions of the sensor entry, that's not open-ended. Requires using fields of view greater than 42 degrees. And not possible thermalize newborn outside of the incubator because it's not possibility for extraction. Look at that. That's the work extremely hard. And do the work from the specialists in real time for asking your questions. This burn is fever without spect areas and no identify by echo sound the point of needs. Really, from us, the neonatal intensive care areas is the no way from the moment from adequate imagings and interpretation is really clear. We are working to generate statistical evidence by guidelines for critical care areas and thermal imagings at scale data from pediatric critical care facilities. Is the phrase for intensive care teams once. Thanks so much. With great science, there is no small country. That's Uruguay and South America. And this, my team works to do unicare intensive care burn areas and intensive care critical care areas. Thanks so much for everybody.
Congratulations, Sergio. I couldn't be prouder of you, one of my most promising students and true example of what we teach through our term. He has fully embraced the protocols he developed and applied them precisely where they matter most in a real-world hospital setting, surgical environments, and wood care. So I know that many other things, a lot of things to present, and today was just a summary of news. Congratulations, Sergio. And you has gone beyond fear, letting go rigid rules that only held back the progress of modern thermography, and go ahead by adopting the point of care concept that we've been teaching recently, and you, Sergio, is doing it very good, right? And if you take one more important step, forgetting the word thermography and use infrared image instead, you will free yourself even more, and no longer be so concerned with room temperature as a limiting factor, but instead understand it as one more variable to interpret with the image itself. So this is the challenge of point of care. And when people understand that it's not thermography, but think like infrared imaging, you understand that the room temperature is an artifact that enriches, not restricts the diagnostic value. And congratulations, Sergio, for following my personal advice to getting professionals in Uruguay. Many of them are here, and in creating the outterm, that it was very important, following the same what we did with Oberterm, and now all together united under the AAT umbrella and the great mother organization that is brought together thermologists and scientists since 1971. And what you're doing is remarkable, and you're not afraid to break barriers, and that I liked so much. And you're not afraid to reveal the true potential of infrared imaging. So congratulations, and I will open here for everybody to open the video and audio and make questions to Sergio. I believe he will reply everybody here and help us to understand much better his experience with point of care. Thanks so much, Sergio.
Thanks.
Congratulations, Sergio. Marcos, it seems that you disabled the video for everyone, so why people is not showing themselves. It's not that we are hidden, it's only that it was disabled.
I'm trying to see how to do this here. Okay. Thank you.
Two questions from John and Juan Jose. Open the, okay.
Yeah, maybe you want Juan Jose to open directly the microphone and speak directly and share your question with Sergio, Juan Jose.
And Jan first, Bebe.
Oh, and Jan, sorry.
Yes, I have seen some software programs that do an excellent job of masking or eliminating certain temperature ranges. Do you believe that with the perfection of both AI use and improved software that we can improve point of care imaging by utilizing the masking of unwanted temperature regions?
Thanks so much,
Do you understand
Jan.
that?
Yes, that's a good question. We comparison from my students saying the phrase, if you need a big brushing your hair to be needs a fine cut your hair. This is the point. At acquiring imaging to be needs from the right in point of care is to strong, soften influence from the variables. Is all to work and talk in the sharing in the last PPT. If only software is not improved, perhaps needs be analyzed imaging if you use perhaps field tools from region area, but the final temperature is affected if you don't perhaps touch by hand from the mother, or needs to be not using remove perhaps and no expected 10 minutes after the acquiring the first imaging, or perhaps the newborn and no removing inside the room from the incubator. Only software, it's not the way, but it's the 50% from the last acquiring imaging analyze. The rest, the 50%, I think to be needs an intensive protocol from acquiring imaging.
Go
I
ahead.
don't know.
Awesome.
Thank you so much.
Thank Jan.
So the next question would be the one from Juan Jose.
Well, first, congratulations, Sergio. Your presentation was fantastic.
Thanks so much.
And my question is, when you're working in the operating room, I think that you need to calibrate the sensor thermal or some way, because I think that the ambient temperature is generally affected by the operating room cooling. Is correct my...
Yes, understood. We work inside the room. We power up the sensors many 15 minutes before use it. Beneath the thermal sensor, establish thermal usage. This is the first point. The next point, inside the room, we need to take a picture from the wall on the area to be approximately down temperature inside the room. Remove all personals for the must be 3 or 4, depends the size of the room from you operating, because perhaps operating room, intensive care areas, intensive burn area, or others. And the system, when flacking is reset the sensors for out time. And for many times, the power system up on, this is establish temperature of sensor. Understood?
Yes, thank you.
We need to apply a Glamorgan, a protocol, it's a classical, and American Academy point of care to be needs 10 minutes minus from the first acquiring imaging inside the room. Depends from the area. Javier.
Yes. Well, first of all, congratulations. Yeah, I like your presentation a lot, Sergio. It's always good to see the thermography in action, like in a real world scenario. It's not a question, it's more like it's not a comment, but like something to think about. For example, you mentioned that there were problems to do thermography inside an incubator because you cannot get the baby out of the incubator and things like that. For example, there are windows that can let through infrared radiation. They use them, for example, in industry. They have like windows and they put the infrared camera and you can see inside the room. Or you could also adapt like a camera directly in the incubator. I guess it all depends on if it's like a huge advantage to have that in an incubator, which I think it is, and trying to convince like hospitals and stuff to get those type of incubators which are infrared ready. For example, like an incubator that's infrared ready, that you don't have to open a door or nothing. You can see from outside, because plexiglass and glass is and polycarbonate, all those materials that they use to make incubators, they're opaque to the infrared, so you don't see anything inside the incubator. But if you have an infrared window. You can put the infrared camera and you can see right through, or maybe attach like one of those little cameras so you can have it there directly and just connect like a USB and have like a TV. So I mean, there's a solution to that. I guess the question would be if there's like a market for that, if hospitals or doctors would be interested to have something like that.
Thanks for your comments, Javier. Yes, neonatal units use two types of incubators. The first is the sharing in this PPT, and the others using incubation used for surgery. This incubator is open upside around 10, 50 centimeters, and that's the way. But no every newborns use that because it is a very high cost, it's expensive maintaining, and only one, I think the hospital we work in is only one too. Now we follow up the used sensor FLIR1 connected because it is the smallest, not edge from the cable, connected for extended cable inside up the incubator. But the real problem is the degree inside the room. This is all hyperradiation imaging. All we need work around. Look at that. This is very important. The low temperature for analyzing imaging inside the incubator is 35 degrees. This is amazing. And the up temperature is 44. Nobody knows now work. The second proposed the follow-up in newborns is extraction newborns outside the incubator. And the neonatals, pediatrics is, oh my God, no more remove it anyway. This is the little big problem. If you use it incubator for surgery, it's no problem for all sensors. But the temperature inside is a real big problem. Thanks so much.
I'm very glad to see many people here. So we are not expecting so many people for this Easter weekend. So I'm glad. And I would like to thank also Betty, Lucia Garcia that are from Sergio team. Is right, Sergio? Your people are here.
Betty, Lucia, Aversa. And the question from Elliot Merkel.
Is that another question? I think no.
Yes. Oh, no, it's a comment.
No, okay.
Sorry.
So before we close, I want to warmly invite all of you to visit the website of American Academy of Thermology and become a member if you're not a member yet. We invite you. As part of our global community, you gain access to exclusive educational materials, advanced training opportunities, and special member-only discounts. So this is the best way to stay updated, involved in the future of infrared imaging in medicine. And welcome to YouTube channel, Spotify, or our WhatsApp group. And thank you so much, Sergio, for your presentation. Very, very amazing. And we hope that you return soon to see to present many other cases. And sure, Sergio and Jen, we are talking before this meeting about the October meeting that we are preparing for members, online meeting, international meeting. And remember, so this October, we will host our World Online meeting through the American Academy of Thermology. It will be a powerful moment to connect, to learn and grow together in this field that we are all so passionate about. And now, as we approach Easter, I want to leave you with a thought. Just like infrared imaging reveals what lies beneath the surface, Easter reminds us to look beyond what is visible, to believe in renewal, hope, and the power of transformation. Let's use this season not only to celebrate, but also to reignite our mission to care, to heal, and to see more deeply, as Sergio showed us to us, and with empathy, with science, and with the light of innovation. On the behalf of American Academy of Thermology, I wish each of you a happy Easter, filled with warmth, peace, and purpose. See you at the next Magical Minutes, and thank you, everybody, to take part with us today. See you. Have a good weekend. Thanks so much, people.
Have a nice weekend.